Alaikum. Hope all of you are keeping well and enjoying this time. My current lecture is the bone tumor. It is my first lecture in uh, the MSK curriculum for the trainee and for the level of the fellows. Just to try to explore uh, the ideas with you, and also if you have any comment or any request, you can message me or send me an email. Um, I will start with the bone tumor because bone tumor is one of the backbone of the radiology generally. The tumors, the neoplasm, and it is some people consider it consists 60 to 70% in radiology because how to know the tumor and how to rule out tumor. So these consist 60 to 70% of radiology. Most of your work daily, of your daily work, is uh, is it a tumor or is it not tumor? And if not tumor, why it is not tumor? Okay. So I will do my best to help you to answer this question. You are not uh, obliged to say the diagnosis of the tumor, but you have to be a safe radiologist, and you are trying to polish your skills and your knowledge so you have the capacity and the capability to help the referrer and how to uh, narrow the diagnosis and differential of the referrer. Okay, bone tumors. We will start. Let's emphasize on some concepts before going into the details. X-ray means in bone tumor it is a detection. It is easy, economic, widely accessible, quick. Detect the majority of the bone tumors. Long bone better than the flat bone. X-ray, you cannot um, give a proper comment on any bone tumor without the X-ray. X-ray is something essential in the bone tumor diagnosis. Okay. The role of the CT is the most important to characterize as either aggressive or not aggressive. It can drive you to the next step, differential diagnosis, for biopsy planning, for staging, for like CT cap, for joint involvement and the neurovascular involvement, especially with the current CT with multi-slices, uh, multi-slices advantage, which where you can the tissue contrast is very good, so you can discriminate the neurovascular involvement. Advantage CT is shorter scan time, tumor characterization, cortical integrity. You can check the cortical integrity, the matrix mineralization, and the periosteal reaction. The MRI has a superior soft tissue contrast, multiplanar image acquisition, high sensitivity for lesion detection, and the critical role in the local staging, especially for the skip lesions, the neurovascular involvement, and the micro micro involvement of the joints and the soft tissue. The common features is low in T1 and the high T2. The tumors everywhere, commonly low in T1 and the high T2. There are some exceptions. High T1 hemorrhage fat, and don't forget melanoma, which is originally some containing some has some precursors of the fatty components. Low T2 mineralization, hypocellularity, hemosiderin or fibrous. So the basic approach of a solitary bone lesion: first, the age, the sex, symptoms, the location, the rate of the growth, pre-osteal reaction, and the matrix. All of these will be explained in details. The bone lesions, either aggressive or non-aggressive. Less than 10 years aneurysmal bone cyst, eosinophilic granuloma, simple bone cyst, from 10 to 20 adamantinoma, aneurysmal bone cyst, simple bone cyst, like that. You can have a screenshot from this screen. And regarding the aggressive, it is very important. The young below 30 and above 30. Below 30, Ewing sarcoma and osteosarcoma and like that. Everything can happen at any age, but this is the common presentation. When you go to older, the more common is multiple myeloma. To be if there is bone lesion, you have to rule out the mates, not osteosarcoma. It's parosteal osteosarcoma or secondary osteosarcoma on top of budget or radiation therapy. Okay. Here is the importance of the age. Can you in the chat give me your impression which is benign and which is malignant?
Porque
In
no hay
the
que
chat.
decir 6 computadoras y tener, o sea, 6 computadoras y 6 espacios.
Okay. No answers? Okay. I will tell you this chondroblastoma and this clear cell chondrosarcoma. Why? Only one factor, the age. If above 30, if above 30, the high possibility of clear cell chondrosarcoma. Below 30, chondroblastoma. Although they have the same radiological features, but the age is very important factor in the diagnosis. And if in the exam either 2A or 2B, you have to build your diagnosis based on the age, because you cannot differentiate between the low grade chondrosarcoma, clear cell chondrosarcoma, and chondroblastoma. Regarding the sex, uh, just I cannot say anything except that only 3 tumors are more common in females. All the bone tumors are more common in males. Uh, these are parosteal sarcoma, giant cell tumor, and aneurysmal bone cyst. You can have a screenshot from this important table regard this classify according to the age and according to the site. The common epiphyseal lesions is chondroblastoma. Don't forget the age. When you go older, giant cell tumor and osteosarcoma, and also when above 40, it is clear cell chondrosarcoma, budget, and subchondral cysts. This, I think, this very famous diagram from, I think, radiology assistant. Regarding the symptoms, it's very important. The symptoms in diagnosing the bone tumors, because malignant, it is most commonly to be painful. Most sarcoma are painful. Pain, it is acute or chronic. What is the character of this pain? It is dull aching, or what is the type of pain? Can wake him up, because so the stoma can wake the patient up. Activity related or persistent. Okay. Pattern of growth. Permeative is the high grade of the high grade malignant tumor and aggressive osteomyelitis. Moth eaten appearance, it is intermediate grade appearance, and geographic, when you find the geographic tumor, it is benign or at least it is low grade malignant tumor. Here it is the when you go to the right side, when you go to the right side, this means that it is more favorable to be aggressive tumor. You see here geographic with the sclerotic limb, geographic, and the one sclerosis at one side, this geographic, and here it is moth-eaten appearance, and here it is the permeative tumor, the permeative pattern of growth, which means that it is highly aggressive tumor. And here's example for the the 1A, it is non-ossifying fibroma Broad's abscess, to 1B giant cell tumor, 1C in chondroma, and when you go to the right, it is very aggressive tumor. Here's the pattern of growth: sclerotic ram, no sclerotic ram, just geographic, moth-eaten appearance, and here it's the permeative appearance. And I hope this is very helpful. Here's example for the geographic, example for the moth-eaten, and the permeative with periosteal reaction. You cannot distinct anything from anything. This geographic, geographic, geographic type 3, 1C. The periosteal reaction, you have it is singular like osteomyelitis or benign tumor or onion skin, where there is, you know that in the onion skin, I just will try to just I want to draw for you uh, is how to in the onion skin you have these relatively slower tumors, so there is in malignant activity, then some, because it is slow, so there is some time for healing. So there is healing sclerotic layer, then in malignant activity, then another boost for healing like that. So when it is bit slow tumor, this will come with onion peel, onion skin appearance. And if it is aggressive tumor, it will present with speculated periosteal action, sunburst appearance, and the Codman's triangle like osteosarcoma. Here is this Codman's triangle is speculated. This is the onion scale. This happened because slow growing tumor come, stop, healing, come, stop, healing, come, stop, healing. So this, it gives the onion skin appearance. Okay, and this brush borders and this absent periosteal reaction. It is septated. All of these are these are favorable to represent benign tumors. It is solid. It is lamellated or onion scale, speculated, and the Codman's triangle when there is speculated and also interrupted. Okay. This solid is single laminated. Here is multi laminated. The single laminated and the multiple laminated, and here is speculated. And when it is interrupted. You will find here this the Codman's triangle. The matrix, we have osseous matrix, cloud-like or amorphous, chondrogenic, chondroid. Chondroid means lucency. When you find to the knee in the or the vertebrae in the X-ray, you find the um, the cartilage, articular cartilage, or you find the disc lucent. This cartilage, this means this is the chondrogenic, and this punctate or C-shaped because the chondrogenic can because of the mineralization in the chondroid matrix gives apparently that's the calcified foci, apparently calcified foci, which are called rings and arcs. And this fibroosseous, which appears as ground glass, it is not lucency, and even in the CT, it is not lucent. It is not the attenuation of the fluid, not attenuation of the soft tissue. It is higher attenuation, and there is no visible matrix. There is so example for the osteoid matrix is Bone Island is very famous with brush borders or clumpy or amorphous or cloud-like that. Okay, here it is the example for the osteoid matrix for benign and the malignant. Osteoid matrix benign in the bone island, osteoid osteoma or osteoblastoma, malignant osteosarcoma, chondroid chondroblastoma, and the malignant chondrosarcoma, fibrous dysplasia, and the non-ossifying fibroma in malignancy, fibrosarcoma, malignant fibrous histiocytosis. The marrow, benign, could be red marrow or conversion or sickle cell disease, malignant multiple myeloma, fatty, it is when benign, it's lipoma, and when malignant is liposarcoma. And the unknown matrix, unknown origin, when malignant Ewing sarcoma, adamantinoma, and the benign giant cell tumor, aneurysmal bone cyst, and eosinophilic granuloma. Here is the osteoid matrix. Example for the osteoid matrix: this bony island, osteoporosis, multiple bony islands, not sparing the epiphysis, which is one of my differentiating point between it and uh, the sclerotic mates, which favor the vascular region metaphysis and the diaphysis rather than the epiphysis, is osteopathy striatum, melanocytosis, one side, follow the dermatomes. The examples for the osteoid matrix, osteoid osteoma, and the osteoblastoma when it is osteoid osteoma with large size. This secondary to radiation, which can be could with time be the osteosarcoma, and there is parosteal osteosarcoma and this tumoral calcinosis. The chondroid matrix, when we have the rings and arcs or honeycombing or calcified, which appears as peripheral calcifications. Here is that these dots, rings, and arcs, the dot of calcification into within lucent matrix. Okay. This example for the chondroid matrix, osteochondroma continuous with the medullary cavity. Here is enchondroma. We have multiple hereditary exostosis. It's very important. They for your exams. And we have this example, this parosteal, with this periosteal chondroma and this chondroblastoma in the epiphysis. And this tribord, this is when that same idea, almost like the osteochondroma, but coming from the epiphysis. Okay. Other example for the chondroid matrix, chondromyxoid chondroblastoma, and chondrosarcoma, and Nora lesions. Okay. Fibrous matrix, non-ossifying fibroma, malignant fibrous histiocytosis, fibrous dysplasia. Take care of the matrix, which is not fluid. The attenuation measurement is very important in this case. Ground glass matrix in the you can see that it is not the lucency of the cartilage. It is ground glass. It is more dense. It is not lucent. This is normal. This is abnormal. This ground glass should exceed 100 Hounsfield units. Okay. This non-mineralized matrix for this intraosseous lipoma of the calcaneum and this the aneurysmal bone cyst. This is not giant cell tumor because you can find the physis. Okay. Osteogenic matrix. This is just collection of the images for and example osteogenic matrix and the fibrogenic matrix, and this uh, uh, the calcifications and this chondrogenic matrix because this with like the chondrosarcoma. So we have a case now. So can you give me your impression? This is an incidental finding, 27-year-old male patient. What is your impression in the chat, please? Don't worry, I will explain to you. Don't worry. Regarding clear cell sarcoma. Okay. So what's your impression? Okay, great. Okay, regarding the clear cell chondrosarcoma, is the chondroblastoma, but in old age. That's it. Nothing else. You cannot differentiate between them by in imaging. Okay, never. Okay, it's just the age. Okay, it's chondroblastoma, epiphyseal. There is no closure of the physis, so of the epiphyseal plate. So this is not this is chondroblastoma. So this sure the patient is younger than 30 years old. Okay. The chondroblastoma in the location more than 70% of the in the long bone epiphyseal have sclerotic margin in the majority. It is eccentric lesion located in the epiphysis. Okay. In the MRI, chondroblastoma, the chondroid matrix appeared high signal in the MRI. Okay. And if sclerotic rim, it will have low signal in high signal in the fluid sensitive sequences, but in the if sclerotic rim, it will have low signal in all pulse sequences. Okay. giant cell tumor. It will appear in the meta epiphyseal region after closure of the epiphysis. Okay, it has eccentric location. There is no mineralization. It can present with bone expansion and periosteal shell. It can show some fluid level or secondary aneurysmal bone cyst. Okay, this Langerhans cell histiocytosis is one of the epiphyseal lesions which appear below the young patients, below the closure of the epiphysis. It shows no calcifications. It is less high T2 signal compared to chondroblastoma. This is very uh, important differentiating point. It is less surrounded with marrow edema. You can see here. This less surrounded with marrow edema compared to the chondroblastoma. The next differential, which can involve the epiphysis, is the osteomyelitis. It starts in the metaphysis because of the vascularity. In early age, it may not be able to breach to the epiphysis, but with time after the closure of the physis, it can breach to the epiphysis. So this is the appearance of the osteomyelitis can from this region. It can comes and involve the epiphysis. Okay. These are other example for the osteomyelitis. You have to find the involvement of the metaphysis first, then the epiphysis. It will never involve the epiphysis unless it involve the metaphysis. So here it is that this Brood's abscess. Osteomyelitis changes are usually late, appearing within 1 to 2 weeks of onset. The acute it will be circumscribed bone lucency with periosteal reaction. Chronic focal sclerosis, Brood's abscess, and appears. You know the involucrum and sequestrum. What is the dead and what is the healthy bone? Can you tell me in the chat, please? Sequestrum is the healthy or the dead bone? Great, thank you. Okay, in the MRI, it's the gold standard because it can show the extension if there is sinus tract involvement of the soft tissue. It's very important. It is intraosseous and supraosseous abscesses will appear as low signal T1, high signal in water sensitive sequences with a thin rim of intermediate T1 signal surrounding the abscess. We have sometimes what's called the ghost sign. Ghost sign. I will explain it later. Peripheral enhancements with low signal in gadolinium may be seen as well as the sinus tract in the chronic low signal in T1 and the T2 with peripheral hypervascular granulation tissue, which may have a role in the ghost sign. You know that in osteomyelitis and some Brood's abscess, the there is peripheral hyper intense signal in the T1, which doesn't persist in the T2, and also there is some these enhancements. Some you cannot see definitely the cortex. If you cannot see definitely the cortex in the T1 and the post contrast, you can see the cortex enhanced. So this is one of the sign that tells you that this is osteomyelitis. Okay.